Good evening, participants and delegates. Thank you for joining Shield Connect today. So today we have a renowned doctor from Mumbai, Dr. Archana Mayekar, and ma'am is going to take the topic clinical practice guidelines on menopause. So before we start with the session, let me give a quick intro of our page Shield Connect as well as a introduction of our speaker for the day. So let me share my screen. So this is our page Shield Connect, where you can find there are various sections are available. So the first section is the blog section, where you can find all the blogs written by the eminent speakers and doctors who are connected with our Shield Connect page. Then we have webinar section, where you can find upcoming webinars and past webinars. So when you click on see more, like if you click on the today's session, so you will have to just register with your email ID and you can join our webinar for today. And participants, you can post your queries in this comment section so that we can have a Q&A session at the end of the webinar. And this is our past webinar page where you can find all the webinars that we have conducted in past. So you can also go through these webinars. Then we have awareness pages like PCOS awareness page, menopause awareness page, GDM, immune booster, COVID-19 and thyroid awareness page. So like if you click on PCOS awareness page, you will find all the videos related to PCOS in different languages by different doctors. Then recently we have a COVID-19 page where you can find blogs and videos related to COVID-19. Then we have our leaders page where you will find all the profile of all the key opinion leaders who are connected with Shield Connect. And we also have a special day pages like Mother's Day, Hypertension Day, Safe Motherhood Day, or Women's Day. So if you click on any one of the topic, you will get the videos related to that topic. Like if you click on a hypertension, you will get the videos related to hypertension. So this is our page Shield Connect. And now let me give a quick introduction of our speaker, Dr. Archana R. Mayekar. Ma'am is MBBS MD DGO, consultant obstetric and gynecologist, and assistant honorary and unit head in VN Desai Municipal General Hospital from Mumbai. So, ma'am, I welcome you on our platform for today's session, and we would like to hand over your session for today's webinar. We welcome you, ma'am.
Good evening, everyone.
Good evening, ma'am.
Yeah. At the outset, I would like to thank Shield Pharma for giving me this opportunity to talk on a very interesting and informative topic of clinical practice guidelines on the management of menopause. So let us start. Next slide. What exactly is menopause, or what is the definition of menopause? Menopause represents the permanent cessation of menses resulting from loss of ovarian follicular function, which is usually due to aging. It's a normal event, it's a natural event, and it is defined as the final menstrual period confirmed after 1 year of no menstrual bleeding. Next one. When is menopause said to have occurred? It occurs naturally or spontaneously. The average age of menopause has been roughly around 51 years over the past many years. And the range of age is around 40 to 58 years of age. There can be menopause also because of premature medical intervention because of bilateral oophorectomy or chemotherapy, and premature ovarian failure or insufficiency, which has got the incidence of almost 1%. Next slide, please. What can be considered as perimenopausal period? A period of 3 years before menopause, followed by 1 year of amenorrhea, is considered as perimenopausal period. It is usually associated with mild ovarian hormonal deficiency. This leads to anovulation and menorrhagia. Next one. So let us have a look at the prevalence of menopause in India as well as the global prevalence. According to Hill, in 1995, the number of postmenopausal women in the world will rise from almost 467 million in 1990 to 1.2 billion by 2030. And most of the increase in this number will occur in developing countries. In India, according to 2016 census, there were around 120 million women aged 45 years and above. And this number is expected to increase to almost 400 million by 2026. So just look at the numbers here. We have almost 48% of population consisting of women, and 11% of these belong to the age group of 40 to 60. So amongst all this, there are around 72% of women are from rural area and 28% are from urban area. So there's a huge scope for perimenopausal, menopausal as well as postmenopausal management. Next slide, please. As you can see the graph here, over the past many years, the age at which menopause has remained constant. However, the life expectancy has increased, and this has led to increase in the number of postmenopausal years the woman is living. Next slide. What is the pathophysiology, exact pathophysiology of menopause? During climacteric, which is another word from menopause, the ovarian activity starts declining. Initially, there is failure of ovulation, so there is no corpus luteum formation, no formation of progesterone. Next stage is Graafian follicle depletion, and this leads to estrogenic activity decrease, leading to amenorrhea. Subsequently, because of the negative feedback mechanism, there is increase in secretion of FSH as well as LH by the anterior pituitary. Next slide. So what happens exactly to the different hormonal levels at menopause? The circulating estrogens, of course, will reduce because there is decrease in production. That's why there is decrease in the ratio of estrogen to androgen. The SSBG, that is sex hormone binding globulin secretion, also reduces. However, the peripheral aromatization of DHEA to estrogens increases. There is reversal of estradiol to estrone ratio, but the testosterone levels or androgen levels are not affected by these. Next one. Just have a look at the different locations where the estrogen receptors are located. And from this, you will be able to understand the symptoms which a patient of postmenopause presents to you. The receptors are present at brain, breast, eyes, genitourinary tract, heart and blood vessels, liver, ovaries, skeleton, as well as skin and hair. Next one. So what are the types of receptors which we have in our body? We have two kinds of estrogen receptors, estrogen receptor alpha and estrogen receptor beta. Both are present in ovary, the central nervous system, as well as many other tissues in the body. The estrogen has got complex effects. It has got beneficial effects as well as deleterious effects on the body. Next one. This is a very, very important graph. As you can see here, we have estrogen secretion and age in years. If you look at the age here, from 40 years onwards, the estrogen secretion gradually starts depleting, and around the age of menopause, that is roughly 50-51, the first symptom which you can see occurring is hot flushes. This is usually followed by mood and sleep disturbances, and sometimes acute cognitive changes as well. Later on, you have urogenital symptoms, you have changes in skin, plus you have cardiovascular disease as well. Somewhere later, you tend to develop osteoporosis, and the last one to develop is cognitive decline, that is development of diseases like Alzheimer's. Here, as you can see, the dotted line, previous one, the dotted line represents the development of subclinical disease. That means here we have a scope to kind of manage the progress of these diseases, especially cardiovascular disease, osteoporosis, and the cognitive decline like Alzheimer's disease. Next one. What are the risk factors which are related to all these menopausal problems. First one being early menopause. Second is surgical menopause or radiation-induced menopause, chemotherapy, your day-to-day practices like smoking, caffeine, alcohol. These things are on the rise, as you all must be experiencing. Many of women patients having daily habits of smoking, increased caffeine intake and alcohol intake, family history of menopausal diseases, and drugs which are used for certain conditions such as generation loss, heparin, corticosteroids, and a prolonged use of clomipene when given over a prolonged period can cause anti-estrogen effect. Next. What are the causes which are responsible for late onset of menopause? First being high parity, second one is use of oral contraceptives, obesity, and alcohol consumption. Next one. There are different kinds of anatomical changes and which further lead to the symptoms of a postmenopausal patient. The main effect occurs on the genital organs. There is always an atrophy and regression of different organs. The ovaries have decrease in their size, they shrink in size, the surface becomes grooved, the fallopian tubes atrophy, cilia of the fallopian tube disappear, the uterus becomes smaller in size, the endometrium remains only up to basal layer, and there is deep straining of the stroma. Next one. Then you have changes in the cervix as well. The cervix becomes smaller, vaginal fornices become, they almost disappear. The vagina becomes narrow. The epithelium of the vagina becomes pale, thin, and dry, leading to senile vaginitis and severe dyspareunia, which are the main symptoms in a patient presenting with menopause. There can be, there is atrophy of vulval area, the skin of labia minora and the vestibule becomes very pale, it becomes thin and dry. There is reduction in the fat content of labia majora. The pubic hair becomes reduced and it becomes gray. The breasts become more pendulous because of the decrease in the glandular tissue, which becomes almost less than 5%. The pelvic cellular tissue becomes very lax. The ligaments also become very lax and they lose their tone, leading to prolapse of the genital organs, stress urinary incontinence, and fecal incontinence in some cases. Next one. So you have here a spectrum of menopausal symptoms comprising of menstrual irregularities, you have neurological symptoms, changes in libido, and you have genitourinary symptoms because of all the changes that we have seen, the anatomical changes in all these organs. The mental and emotional symptoms could be, they vary from depression, irritability, mood swings, there can be cry spells, the nature of the woman becomes more suspicious, there can be emotional lability, the lack of concentration. The vasomotor problems are mainly hot flashes, you can have skin redness, sweating, palpitations, dizziness, headache, anxiety. Lots and lots of symptoms can be related to menopause. The menstrual irregularities is a mainstay. Patient can have a spectrum of menstrual irregularities like heavy menses, she can have scanty menses, she can have early menses or delayed menses, she can have prolonged periods, she can have missed periods, and there can be abnormal menstrual flow. The urinary and vaginal changes mainly lead to vaginal itching, there can be a lot of discharge, there can be frequent urination, there can be dysuria, and there can be dyspareunia as well. Next one. Now, hot flushes, almost 75% of postmenopausal women suffer from this. This is the very first and acute symptom of estrogen deficiency, and the patients really suffer because of this. They get scared because of this. This is usually followed by severe sweating, usually occurs at night and may disturb sleep also. It is sometimes preceded by headache and can be confused with migrainous headache if patient is suffering from migraine. There can be mental depression due to lack of sleep, irritability, and lack of concentration. However, with passage of time, the severity of hot flushes decreases. Usually, you tend to get hot flushes within first 1 or 2 years of postmenopause, but it can get prolonged to almost 10 years as well. Next slide. What is the exact cause of hot flushes? It basically happens because of the deficiency of estrogen, which reduces the hypothalamic endorphins, which again release more norepinephrine and serotonin, and this causes the disturbance in the thermoregulatory system, leading to inappropriate heat loss mechanism. Next one. What are the neurological presentations? There can be various vasomotor symptoms are because of neurological causes, and there can be paresthesia in the form of sensations of pins and needles in the extremities. Then you have hot flushes, headache, faintness, numbness, itching, back pain. Next one. The symptoms which usually develop little later are because of the genitourinary syndrome of menopause. It consists of urinary symptoms like dysuria, stress incontinence, urge incontinence. There can be recurrent UTIs, there can be urethral caruncle. The genital symptoms include dry vagina, dyspareunia, loss of libido, and in few cases, there can be fecal incontinence, which can be really, really difficult for the patient to manage. Next one. What are the different menstrual irregularities you have? You have heavy menstruation, you can have scanty menstruation, early or delayed menstruation, and you have prolonged periods or menorrhagia. The mental and emotional symptoms include, there is a spectrum of symptoms, again, varying from depression, irritability, mood swings, emotional outbreaks, fatigue, poor memory, lack of concentration. Next one. What are the usual complications which can really affect the patient's life and the quality of life? The orthopedic complications include arthritis, osteoporosis of vertebral bones, especially upper end of hip joint and wrist. In the form of ischemic heart disease, myocardial infarction, hypertension, stroke, cardiac irregularities, and tachycardia. Next one. Prolapse genital tract, stress incontinence of urine, and fecal incontinence. You have inocolonic cancer. Then you have cognitive decline, which is a late symptom to appear, say, after 60 or 65 years of age, and can lead to Alzheimer's disease. You can have, the patient can have cataract, glaucoma, and then you have skin changes and tooth decay as well. Next one. What is exactly is osteoporosis? It's a slowly progressing of bone mass resulting in increased fragility and predilection to fracture due to estrogen depletion. Next one. The cardiovascular disease, the main factor responsible for this is again estrogen deficiency, because as you all know, estrogen is a cardioprotective hormone. It also has got antioxidant properties. So after menopause, you have a lot of differences and changes in the lipid metabolism. You have decrease in the protective HDL, you have increased LDL, the total cholesterol levels increase. Also, this can lead to atherosclerosis, ischemic heart disease, myocardial infarction, and the risk factors which increase the incidence of cardiovascular diseases in such women is obese women with hypertension and previous thromboembolic episodes. Next one. There is also increase in the incidence of stroke, of course, secondary to increase in atherosclerosis. Next one. Let us talk about the hormone replacement therapy, which becomes the mainstay of this menopausal or postmenopausal management. And next one. As you can see here, the graph showing the levels of progesterone and estrogen over a period of age 25 to age 75 of the woman. As you can see here, there's almost 75% reduction in the progesterone hormone beginning from the age of 35 to 50. But at the same time, the estrogen reduction is only 35%. So relatively at the age of 50, when the patient reaches menopause, there is high estrogen concentration or high estrogen levels compared to progesterone. Next one. What are the rough or main indications of HRD? The HRD has to be started according to the patient's symptoms and the amount of suffering the patient gets because of these symptoms. So you start HRD in patients to relieve, have HRD for prevention of osteoporosis, again to maintain the quality of life in menopausal years. And special indications for HRD include women who have premature ovarian failure. As I told you, the incidence is almost 1% in cases of gonadal dysgenesis and also in cases of surgical or radiation menopause. As you see here, the HRD consists of either estrogen plus progesterone or it can be estrogen alone. And then you have topical estrogen applications. The estrogen plus progesterone is given preference in patients when the uterus is intact or the patient has not undergone hysterectomy, so that the endometrium gets protected against the effects of progesterone, against the effects of estrogen, sorry. The estrogen alone is suitable for women who have had hysterectomy. And of course, vaginal estrogen therapy is useful for women who have had local symptoms such as vaginal dryness. Next one. This is a very important slide. It tells us that the consideration of HRT should be part of overall strategy, including lifestyle recommendations regarding diet, exercise, smoking cessation, and safe levels of alcohol consumption for maintaining the health of peri and postmenopausal women. Because there are some women who might feel that only starting HRT is going to change everything and it's going to work like a miracle. It's not going to be like that. So you have to consider all these factors in toto and then give treatment to the patient. Next one. So HRD should not be recommended without a clear indication for its use, that is significant symptoms or physical effects or estrogen deficiency should be present. Postmenopausal HRD is not a single regimen given to a standard woman. It has to be individualized and tailored according to the symptoms and the need for prevention, as well as personal and family history, results of relevant investigations, the woman's preferences, expectations, and her choices. Next one. What do you mean by early menopause? There are some women who experience early menopause. It can be either spontaneous or it can be iatrogenic, usually considered when the patient gets menopause before 45 years and particularly before 40 years. They are at higher risk of cardiovascular diseases and osteoporosis, and there may be increased risk of affective disorders like Alzheimer's as well as dementia. In such women, the use of HRT may reduce these risks, but the evidence for this is very limited. Next one. What should be the duration of therapy? There are no reasons to place mandatory limitations on the duration of HRT. Whether or not to continue therapy has to be decided at the discretion of the well-informed woman or health professional, depending upon the specific goals and the objective estimation of ongoing benefits and risks. Benefits and risks have to be always weighed, and then the treatment has to be started and continued. Next one. What should be the dosage of HRT? The dosage has to be again titrated to the lowest effective dose. This has to be kept in mind. Lower doses of HRT that have been used previously may reduce symptoms sufficiently and always maintain the quality of life for many women. Next one. What should be the pattern of counseling for such women? Women taking HRT have at least should have an annual consultation, including a thorough physical examination, update of medical and family history, relevant laboratory and imaging investigations include a sonography, mammography if required, and discussion on lifestyle and strategies to prevent or reduce chronic disease. Next one. Let us talk a little about progesterones. In general, progesterone should be added to systemic estrogen therapy in all women with a uterus to prevent endometrial hyperplasia and, of course, future risk of endometrial cancer. However, low-dose vaginal estrogens administered for the relief of urogenital atrophy are systemically, though they are systemically absorbed, but the levels don't reach such levels which warrant the use of concurrent progesterone. Next one. What are the safety considerations regarding progesterone? The Women's Health Initiative study, it suggests that it is the progesterone component of HRD that is more significant in any increase in breast cancer risk rather than the estrogen itself. Next one. Natural progesterone and some other progestrogens have specific beneficial effects that could justify their use besides the expected actions on the endometrium. For example, when you use drosperinone, it has got a well-documented blood pressure lowering effect. Also, progesterones may not be alike in regard to potential adverse metabolic effects or associated breast cancer risk when combined with long-term estrogen therapy. Next one. What about androgen therapy? Androgen replacement therapy should be reserved for women with clinical signs and symptoms of androgen insufficiency. Androgen replacement often has significant beneficial effects in women who have undergone bilateral oophorectomy or those who have had adrenal failure, particularly on health-related quality of life and sexual function. It has been shown that androgen therapy may help in moderate to severe cases of sexual dysfunction. Next one. Now here comes another important topic in postmenopausal age group, and that is osteoporosis. HRT is effective in preventing bone loss associated with menopause. It decreases the incidence of all osteoporosis-related fractures, including the vertebral and hip fractures, even in women who are not at high risk of fracture. The initiation of HRT for the sole purpose of prevention of fractures after the age of 60 years, however, is not recommended. Continuation of HRT after the age of 60 years for the sole purpose of prevention of fractures should take into account the possible long-term effects of specific dose, the method of administration of HRT compared to other proven non-hormonal therapies. Next one. The protective effect of HRT on bone mineral density declines after you stop the therapy at a very unpredictable rate. However, some degree of fracture protection may remain even if you stop HRT. But if the patient is still considered at high risk of fracture after stopping of HRT, additional therapy, which has got proven bone sparing medication, should be given. Next one. So what are the risks of hormonal therapy? The main deterrent in starting HRT in most of the patients by many of us. First one is the endometrial cancer. Second one becomes venous thromboembolic disease, the risk of which increases within 1 to 2 years after initiation of hormone replacement therapy. Breast cancer, there is increased breast density with progestrogens via proliferation of estrogen-dependent mammary tissue. And this makes it very difficult to detect breast cancer at early stage on a mammogram. The risk of ovarian cancer, it increases after almost 10 years of estrogen therapy. Also, there is increase in the risk of cerebrovascular accidents. There can be changes in lipid metabolism, like increased incidence of gallbladder disease, which is due to increase in the levels of cholesterol. Next one. Next slide. Yeah, what are the different medications which are previous one? Previous slide, please. Previous slide, please.
Yes, ma'am.
No, previous slide before this.
Is my screen visible? Medication?
Yeah, but you skipped the previous slide. Anyways, we've had different formulations which are, yeah, right. You can have conjugated equine estrogen and
Yeah.
hydroxyprogesterone acetate, which is given by oral route. Again, there is evidence for protection against loss of bone mineral density. Tibolone is another synthetic molecule that has got affinity. No, this was right. Continue with the next slide, please. Next one. Yeah, tibolone is a synthetic molecule that has got affinity for the estrogen, progesterone, and as well as androgen receptors. And this has got proven efficacy against vertebral as well as non-vertebral fractures. There are other medications like SERMs, selective estrogen receptor modulators like raloxifene and desdoxifene, which reduce the risk of vertebral fracture in postmenopausal women with or without prevalent vertebral fractures. There is a combination of desdoxifene and CEE, which is shown to preserve bone mineral density. And the advantage of desdoxifene here is that it protects the endometrium as well. So you don't require addition of progesterone in this formulation. Next one. Sorry. Next slide. Yeah, what are the different hormonal therapy formulations available in India? Previous one, don't skip it very fast. Previous slide, please. Previous one. Previous one. Yeah, the different formulations available in India are as follows. No, the next one, please stay with that slide. Next slide, please. Yeah, just stay for a minute here. You have oral preparations in estrogen like conjugated equine estrogen, you have 17 beta estradiol, you have estradiol valate in different formulations, and the therapeutic doses is different for each of them. Then you have transdermal estrogen gel. Sorry. You have progesterone preparations like dydrogesterone, micronized progesterone, and levonorgestrel intrauterine device, which releases almost 20 micrograms of levonorgestrel per day. Then you have combination of estrogen and progesterone. You have single tibolone, which is used in the doses of 2.5 milligrams daily orally. And then you have estrogen therapy for genitourinary syndrome in the form of local applications like estriol cream. You also have oral estriol for the same symptoms, and you have conjugated equine estrogen formulation in the form of a cream. Next one. Now, what are the non-hormonal therapies available for these symptoms? Next one. As you can see here, the postmenopausal women need a dietary reference index or DRI of almost 1000 to 1200 milligrams of elemental calcium. Remember, one point to be remembered here is that calcium supplementation should be restricted to bridge the shortfall between dietary intake and the DRI, and to patients being treated for high risk, high fracture risk. Routine dietary calcium supplementation cannot be justified in terms of efficacy and health economics. So a patient who is having good dietary intake of calcium does not require calcium supplementation. Excessive calcium supplementation can lead to cardiovascular disease or some cardiovascular side effects as well. Calcium supplementations, as you can see here, in excess of DRI may induce cardiovascular harm. Next one. The DRI for vitamin D is 800 to 1000 international units in post-menopausal period. But vitamin D supplementation per se has shown independently to reduce the risk of fracture and of falling in elderly patients. So here we have vitamin D to be playing a major role. Next one. Next slide. What is the role of bisphosphonates? As you know, bisphosphonates are the potential inhibitors of bone resorption, and they decrease the rate of bone turnover with proven efficacy in the prevention of vertebral as well as hip fractures. You have different kinds of bisphosphonates available, like residronate and alendronate available. A drug-free holiday may be considered after 3 to 5 years of bisphosphonate therapy in patients with a good bone mineral density response to treatment without any prevalent fractures. They have benefit in some cancers and may prevent bone metastasis from breast cancer. Bisphosphonates, you have to remember, they are available in different formulations, and some drugs are taken on weekly basis, some can be taken on monthly basis. The only thing which you should remember here is bisphosphonates can cause severe acidity and acute ulcerations of the stomach as well as duodenum. So the drug has to be taken in upright position, sitting in upright position and on empty stomach with a large full glass of water, and nothing has to be taken for half an hour after taking the drug. Next one. Next slide. What are the SERMs which are used for prevention of osteoporosis? You have raloxifene, you have lasofoxifene, and you have basedoxifene, which reduce the risk of vertebral fracture in postmenopausal women with or without prevalent vertebral fractures. As I told you earlier, the combination of basedoxifene and CEE has been shown to preserve bone mineral density. Raloxifene is also indicated for reduction in risk of invasive breast cancer in postmenopausal women with osteoporosis. Next one. This drug, which is parathyroid hormone, it has got a unique quality because it is difference in its action. As majority of the drugs seen previously, which are used for osteoporosis, you have seen that they act in preventing the resorption of the bone. Whereas parathyroid hormone is a drug which helps by stimulation of bone formation. It produces a significant reduction in the risk of vertebral and non-vertebral fractures. However, there is no indication that combining parathyroid hormone with bone resorption inhibitor has got any additional benefits. Whenever you want to use parathyroid hormone, it has to be given for a maximum period of 18 to 24 months only. And the prior treatment with bisphosphonate blunts the effect of subsequent parathyroid hormone. Next one. There is a role of strontium to a certain extent because given in a daily oral dose, it significantly reduces the risk of vertebral and non-vertebral fractures in osteoporotic and osteopenic patients, irrespective of the presence of a fracture or age of the patient. The mode of action of strontium ranelate involves stimulation of bone formation as well as inhibition of resorption. Next one. Next slide. What are the drugs which are available for alleviation of vasomotor symptoms? You have, other than HRT, though HRT remains a mainstay of vasomotor symptom treatment, the other medications include selective serotonin reuptake inhibitors, you have selective noradrenaline reuptake inhibitors, and then you have gabapentin and pregabalin. In short-term studies. However, their long-term safety needs further evaluation. The high-quality studies to date have not supported the efficacy of complementary or over-the-counter therapies in reducing severity or frequency of hot flushes and night sweats. There are certain natural ingredients which are available for these, and they are black cohosh and salt products, but these are not superior to placebo in the treatment of hot flushes. Next one. There are certain medical herbs with the following active ingredients which have shown promising results. And these have been time tested in especially countries like Korea and China. There are these herbs by the name Sinentum bilfordi, then you have Phlomis ambrosa, and then you have Angelica gigas. These have cinnamic acid, S-methyl ester, decursin, and decursinol angellate as the main ingredient. Next one. Next one. As I've told you earlier, cinnamic acid is a natural remedy used for hundreds of years in Korea and China, and it has shown a significant improvement in the quality of life of women dealing with symptoms of pre, peri, and post menopause. Next one. So here again we have a product called Estrogen 100, which has to be given in the dosage of one tablet twice a day. It is effective in perimenopause, menopause, as well as postmenopause. It basically acts by regulating the estrogen affinity for the estrogen receptors. It upregulates certain receptors and causes downregulation in certain receptors. The upregulation occurs in vasoendothelium, central nervous system, and bones, and the downregulation occurs in breast and endometrium. So there is no proliferation of endometrium, and the risk of breast cancer also is not there. On vasoendothelium, it reduces the incidence of hot flushes and night sweats, and it improves mood swings and insomnia, and it improves increase in the bone marrow density. Next one. Next slide. Here you have studies which indicate the evaluation of effectiveness and safety of estrogen on perimenopausal women for a period of 1 year. And as you can see, there is improvement in bone health parameters significantly. Next one. Next slide. The evaluation of the efficacy and safety of this product on menopausal women, on menopausal symptoms over a period of 12 weeks in a multicentric randomized double-blind placebo-controlled clinical study shows that there is definitive and significant decrease in the incidence of hot flushes, and there is a definitive improvement in the menopause index, which can be seen in this left-sided graph. Next one. Now, what are the results with Estrogen 100? If it is used for 12 weeks, there is statistically significant improvement in the quality of life. Major 9 symptoms are improved to a great extent, like hot flush, night sweats, parenthesis, nervousness, melancholia, fatigue, rheumatic pain, vaginal dryness in all peri, post, and menopausal women. However, there are no adverse effects reported with this product. It was found to be safe and effective herbal formula that can improve women's quality of life and various menopausal symptoms. Next one. Next slide. According to these studies, there is no toxicity seen even with 2 grams per kg body weight of the dosage. Next one. Next slide. So here we again go with few recommendations by the Indian Menopause Society. As you can see here, the mainstay of the treatment or the therapy remains therapeutic lifestyle management. I think with the pandemic going on, everyone is so well versed with lifestyle management because this has become the in thing in managing everything. So as you can see here, there's a 3-step management of menopause. You have to eat right, exercise right, and then with the help of indicated medications, you can lead a very quality life. Next one. What is a therapeutic lifestyle management? It includes a spectrum of various things like increase in the physical activity. The woman has to do targeted exercises like muscle strengthening exercises and functional exercises to improve the stability of the joints and muscle mass. She has to give importance to her nutrition. She has to avoid alcohol and tobacco to a great extent. She has to follow stress reducing strategies like doing yoga and breathing exercises, meditation, paced respiration like pranayam. She can take advantage of doing body massages. Then she has to have emotional stability by diverting her attention, doing meditation. She has to maintain positive attitude. The family has to be involved in this management because most of the time it is seen that a menopausal or perimenopausal woman suffers alone. The whole family thinks that the woman has gone mad. spiritual attitude can also help her to a great extent. And most important thing is good quality sleep. Next one. Again, you can see here the balanced and nutritious diet forms the mainstay of this therapy. You can take the guidance of a proper dietitian and follow the diet which is useful for your body, and it also has to be customized and tailor made according to the pattern and the metabolism of that particular woman. Next one. Next slide, please. What are the general recommendations which are given for such women? The sugar intake should be maximum 6 teaspoons per day. The salt intake should be maximum 1.25 teaspoons. What I'm talking about is all maximum levels which are given. These are the recommendations by Indian Menopause Society. Fruit intake around 100 grams per day, vegetables 300 grams per day. Drink at least 6 glasses of water every day for proper hydration. And you can add powdered flaxseed, cinnamon, fenugreek, and soft in salads and curds. Next one. Next slide. Regarding tea, coffee, and dairy products, the patient has to be advised to avoid excessive intake of caffeine and tea as well. Patient can consume a minimum of 500 ml of milk or curds, preferably low fat, to build on her calcium banks in the bones. If the dietary intake is adequate, as I've told you earlier, there is no need to supplement calcium orally. This diet has to be supported with lots of vitamin C rich fruits and vegetables, which help a lot in calcium absorption. Next slide. Next slide, please. If you look at the sleep hygiene which is required in menopausal women, we should advise them to go to sleep at a particular time and get up at a particular time. This has become really difficult in today's times with the use of mobile phones, and the patients are on the mobile phone till 1 o'clock, 2 o'clock, binge watching serials on Netflix and Amazon Prime. So the patient has to be told about the importance of good quality sleep, timely sleep in a proper environment, preferably in a dark, quiet room at a comfortable temperature. Comfortable temperature plays a very important role in managing hot flushes. Avoid large meals, do proper exercise, and reduce in intake of caffeine, nicotine, and avoiding liquids 2 hours before sleep can help you a lot in having good quality sleep. Also, it is advisable to maintain dim light bedroom environment with no gadgets around. No gadgets around should be the key word in any advice you give to any patients, not only menopausal. I think everyone must be knowing the role of blue light emitting from the mobile phones, especially in PCOD patients, in young girls as well. Next slide, please. Yeah, this is the last slide. Thank you so much for your attendance. I would like to advise about one thing here, that recently I read somewhere in newspaper that the life expectancy of Indian women, especially, or women from developing countries, has increased, but the quality of life what they have, especially women, is reducing, and that has to be taken into account. That has to be remembered. We are the main advisors for such type of patients, and you have to start advising these patients right from the time they attend your antenatal clinics. Thank you so much.
Thank you so much, ma'am, for giving all the detailed information like how to manage menopause from HRT to non-HRT to exercise and lifestyle intervention. So let me check if we have any queries from the delegates in comment section. 1 minute, ma'am. So, ma'am, what is your view on COVID? Recently, most of the questions are regarding that. Is there any effect of COVID on the menopause? symptoms or menopause to the patient?
I have per se not seen any postmenopausal or perimenopausal woman coming to me with specific
Mm-hmm.
symptoms or any increased incidence. But I
Mm-hmm.
think in general, if you look at the population, the thromboembolic events have
Mm-hmm.
seen a sharp rise in general population as well. So I think
Mm-hmm.
that it must have caused definitely some change in that.
Okay, ma'am. And ma'am, what is your recommendation according to you? What diet should be given to this patients, menopause patients?
So menopausal patients, basically you have to consider into account their daily requirement of various vitamins, minerals. The fat content has to reduce. The general advice which we give for any kind of a diet, they
Mm-hmm.
have to remain physically active. So the protein content has to be definitely slightly, not
Mm-hmm.
exactly very much like young
Mm-hmm.
patients, but a balanced diet containing less of fats
Yes.
and carbohydrates and proteins which balance each other. You cannot deplete or totally cancel out fat because it is essential for the texture of your skin as well as maintaining
Yes.
the tone. So you cannot totally cut off the fat. They have
Mm-hmm.
to increase calcium intake, as I told you, low fat or skim milk, and physical activity is going to help them a lot because we've seen in Indian people
Sorry, ma'am, it is on mute. Yeah.
sorry.
Yeah. Okay.
Hello.
Okay. Yes, ma'am.
Could you
Now we
hear?
can hear you. Yes, we can hear you now.
So majority of my patients, or I think everyone must be experiencing that, majority of them are with very high BMIs. We are not at
Mm-hmm.
all well versed with the side effects of this and leading to osteoarthritis and severe osteoarthritis of the knee, and then later on
Mm-hmm.
requiring replacement, major disabilitating condition we see in postmenopausal women.
Okay. And ma'am, how do you counsel with the patient's relative who are coming with such patient? Do you also recommend them to
Yeah,
help
as I
them?
told you, yeah,
Yes.
the I could see the mental kind of imbalance increasing a lot
Yes.
during this,
Yes.
and there is, in fact, I've seen certain few of my seniors also commenting on any woman who behaves in a little different way, saying that she must be postmenopausal. I mean, this is not the right thing to say.
Yeah.
Very sarcastic remark, but that is because many of them have kind of instability and there's nobody in the house to support them. So you
Okay
have to
then.
really counsel them if they have such major symptoms like irritability, mood
Hmm.
disturbances, and they can go into depression, sudden
Hmm.
outbursts of anger, and
Hmm.
the woman feels very lonely. So
Hmm.
it requires proper counseling of the family members, as well as the woman can also take the help of a counselor, which is a little taboo or stigma in our population. So
Yeah, the
better
psychotherapy.
consult a psychologist who can help her a lot.
Thank you so much for giving all the answers to these questions. And we are glad to have you on our platform for today's webinar. And we would like to have you for more sessions on our platform, ma'am.
Thank you so much. Thank you so much, Sheel, once again. Thank you, all
Thank
the
you, ma'am.
participants, for giving your time. Thank you.
Thanks a lot, madam.
Yeah, thank you. Thank you so much.
Thank you.
Thank you, participants, for joining today's session. So we will end this session. Bye. Bye, ma'am.
Thank you.